Hi, this is Elliot Fishman, and welcome to our newest talk. And this is going to be on basically renal inflammatory disease from infection through infarction, what you need to know, what are the key differential diagnosis points, what are the pitfalls, and what do you really need to know to be successful in clinical practice. Now, we've spoken about the timing of data acquisition, and we speak about this more probably when we look at renal masses and determine when a renal cell carcinoma is easier to see. We talk about the vascularity in the early phase or corticomedullary phase. We talk about the nephrographic phase, and then we also talk about the excretory phase. We also will get non-contrast scans often when we're doing tumors, but I would have to admit in the routine ER scenario, unless you're thinking about stone disease, you're typically not getting a scan without contrast. Now, in terms of phases, most people typically get a single phase imaging study, typically venous, so maybe they're at 90 to 120 seconds. That often is successful, but it's not perfect. If I had an optimal acquisition, I probably would have both corticomedullary and nephrographic phase imaging. It also should be noted that excretory phase imaging can prove very valuable. If you think about what was the classic best phase on IVPs for looking for renal infection, that was that striated nephrogram of the excretory phase that Bosniak spoke about so many years ago. So the thing is, we're not always going to have all the phases, so I'm going to try to show you what looks good and what we're seeing in each phase. Corticomedullary differentiation is important, and I really like that phase because it shows a range in pathologies from vascular pathology like renal artery stenosis or even potentially renal vein thrombosis to inflammatory disease, be it pyelonephritis or infarcts, to a range of neoplasms from clear cell renal cell carcinoma to oncocytomas to papillary renal cell carcinomas. And we're going to think about these changes in this talk again, focusing on non-malignant pathology. This article by you way back when said the renal cortex enhances briskly from its non-contrast appearance of about 30 to 40 Hounsfield units to 70 at 25 to 35 seconds to 145 at about 50 seconds. The medulla enhances only minimally to 50 at 40 seconds and 90 at 50 seconds. So when we're in that range of 30 to 60 seconds, we're going to see a difference in enhancement between cortex and medulla. And this differentiation typically peaks at about 100 Hounsfield units, but it's really going to help me in making very specific diagnoses. So corticomedullary phase, ideal for arterial structures, ideal for preoperative planning, not only recognizing what the renal tumor is and defining its vascularity, but determining whether or not it's a good candidate for partial nephrectomy, which we would like to do in nearly all cases. We look for changes in perfusion on the corticomedullary phase, which can be a range of things from tumors to infection to infarction, and some tumors, particularly smaller ones, may only be seen on corticomedullary phase because the lesions do enhance, and if you look at later phases only, you might just assume it's a high-density renal cyst. Simple example, non-contrast scans, lobulations in the right kidney, and there you see a very vascular mass at about 30 seconds post-injection. Very classic for clear cell renal cell carcinoma. The corticomedullary interface in the contralateral left kidney looks normal. And here's that same patient, the vascularity on the early phase imaging at 30 seconds, stranding and collaterals around the kidney, and the infiltration of the kidney by tumor, the changes in the corticomedullary interface nicely shown. Compare the tumor on the right with the normal kidney on the left. Now, when we speak about renal infection, the spectrum is large. Most of the time, we're talking about acute pyelonephritis, which is due to E. coli. On the other spectrum are rare things like tuberculosis. The more severe the infection, the more the perfusion changes are present, and changes are usually unilateral, but they can be bilateral, they can be focal, or they can be global. They can be multifocal in the same kidney. Now, when you think about infection, it's more common in women. I mentioned E. coli is the number one possibility in terms of what etiology it is. In most cases, the CT scan is not necessary. If you think a patient has a urinary tract infection, do urinalysis and treat. Most of the time when we're doing pyelonephritis on CT, it's a patient who has known pyelo, who has been treated but is not doing well and continues to be febrile, and you're worried about complications like abscesses, or in patients who are diabetic or elderly or immunocompromised, where you worry about more severe infections. So it's the more unusual cases, the more cases where you expect complications, that we will be doing CT scanning. In terms of non-contrast scans only, well, the issue is you might see pyelo or suggested because one kidney looks larger, or there's perirenal stranding, or the kidney looks edematous. But I think to really make the diagnosis in every case, you need IV contrast material. The things we look for changes in renal contour. We look for changes in parenchymal attenuation, typically decreased attenuation. We look for alterations in contrast enhancement, where it's not as bright in the cortex and medulla in one kidney compared to the other. And we look for decreased rate of contrast excretion. Again, with infection, often excretion is delayed. And then perinephric or perirenal abnormalities. We commonly will see this. It's not necessarily the case. In the more severe infection, surely with abscesses, we're more likely to see changes in the perinephric space. With just a routine E. coli pyelonephritis, it's going to be less common. Some examples. Here you notice this stranding by the left kidney. The left kidney shows edematous changes and what looks like fullness in the renal pelvis. So you know something's going on. The truth is this could still be a tumor potentially. When you give IV contrast, here's about a 30-second scan, corticomedullary phase. You see multiple areas of patchy decreased enhancement in the left kidney, very classic for acute pyelonephritis. The stranding, the low density, and the lack of sharp margins pushes you to infection. In case you were thinking about infarction, usually things are better defined. Yes, with infarction, you may see thrombus in the renal arteries, but often you won't because there'll be small emboli to the kidneys. But with infarcts, they're usually a lot sharper. Here, the stranding as you go to the venous phase at about 70 seconds. You can see the stranding laterally, the stranding in the kidney, and this is a good example of infection. Another patient, this is a sickle cell patient. Look at the left kidney. You see the loss of cortex medullary interface. You see the kidney is enlarged, left compared to right. The right's enhancing normally. This is edematous and it's low density. There's loss in the cortical margins. You can see it here as we go to the lower pole. You can see all of the signs: enlarged kidney, changes in cortical medullary interface, decreased attenuation, perirenal stranding. And here it is on the coronal view as you go to venous phase imaging at about 70 seconds. You again see the differential changes, left kidney compared to right. And then as you keep going, if you went on excretory phase, you would see the changes very similarly, probably with a striated nephrogram. Another example, patient had fever. There was a question of stone disease. I don't see any stones. How do the kidneys look? Well, they look fairly symmetric, but when you give IV contrast, you can see that there are areas of decreased attenuation, multiple areas, in fact, in both the left and right kidney, a little bit worse in the left than the right. But that's a classic example of pyelonephritis where both kidneys are involved. The coronal view, I think, is very helpful because when you want to see things globally, whether it's infarcts or infection, at times the coronal view and sometimes the sagittal view makes it easier. I particularly like the coronal view because it really lays out the corticomedullary interface very nicely. And here it shows you involvement of both kidneys. When we get the late phase imaging, I mentioned the striated nephrogram, which was described by Bosniak. You can see the decreased attenuation. The striated nephrogram is typically with infection, and it's best seen and may only be seen on excretory phase imaging. One thing to mention, if you only have early phase imaging, say corticomedullary phase at 35 seconds, you could miss subtle cases of pyelonephritis. If you're looking for pyelo and you only gave me one phase, I probably would do excretory phase, and I would do best at getting all of the correct answers. Here again, it's that same patient, that striated nephrogram appearance, the areas of decreased attenuation involving upper, mid, and lower thirds of the kidneys bilaterally. Now, I mentioned that we don't routinely do non-contrast scans, and this in great part is because we want to minimize the radiation dose. When I'm doing tumors and I'm staging a tumor, I'll do non-contrast to define the renal enhancement. Non-contrast is good for picking up stones, though I have to admit, in most cases, I could see the renal calculi on the corticomedullary phase at 30 seconds. But non-contrast can be helpful. On the other hand, a lot of times in the ER, people say, oh, we don't want to give contrast. Let's just do non-contrast. Well, I have to tell you that non-contrast is going to miss a lot of things. No, it's not going to miss stones, but it is going to miss small tumors, particularly tumors that don't change the contour of the kidney. It's going to miss acute pyelonephritis when the kidney is not markedly enlarged and perirenal space involvement. And it will miss also vascular pathologies like AV malformations, for example. Here's a nice case in terms of renal inflammatory disease. You look at the kidneys. The right kidney, the corticomedullary interface is there, and the left kidney is basically gone. As you follow this out, you can say, well, what gives me corticomedullary differentiation persisting? It can be infection, it can be obstruction, often by stone disease. So in this case, at 70 seconds, the corticomedullary interface is gone on the left, but on the right, it's persistent. Persistency of the corticomedullary interface getting past 50 or 60 seconds, that is one of the good signs of renal inflammatory disease. And you can see it very nicely here, this slight dilatation of the renal pelvis, and we were able to find the stone. So when you have obstructing stones, even small stones, you can see changes in the perfusion of the kidney. And here's just a few more 3D images showing you the kidney in that case. Now, I mentioned about non-contrast. Sometimes you can make the diagnosis. Here, both kidneys look like they're stranding, but especially the left kidney. The left kidney's larger. That's going to be pyelonephritis. I guess I could say there's a tumor present, and we definitely know there's pathology in the left kidney, but I would go with pyelo most likely. And then as you look at the study with contrast, you can see the left kidney is enlarged, the corticomedullary differentiation persists, and there's stranding around the kidney. A very nice example of pyelonephritis, though one would have to admit there is a little bit of pyelo in the patient's right kidney, but the main abnormalities are going to be in the left kidney. Now, we see lots of patients with sepsis. This was a patient with MSRA sepsis. These patients often do poorly, and you can see this patient is hypotensive. Look how bright the adrenal glands are. That's a great sign for hypotension. You'll look for a flat IVC and changes in bowel. But look at the kidneys. The kidneys basically show essentially lack of corticomedullary interface. There's some enhancement of the kidneys, but it may just be persistent enhancement from a prior study. One of the things you see with sepsis is a lack of renal enhancement. It's one of the good signs for sepsis. And here's that patchy loss of corticomedullary interface, some enhancement in the kidney, but no excretion of contrast material, and very bright adrenals. A really nice example showing you what sepsis will do to the kidneys. Now, renal abscess is something that's important. Patients, particularly diabetics or patients immunosuppressed, if their renal infection is not treated well, it could go on to abscess. And abscesses can at times simulate tumors. They can be low-density masses. They can be cystic with thickened irregular walls, hence the confusion at times with a tumor. You can see thickening of gyrotous fascia and perinephric extension. Abscesses can be single or multiple, and they could be, usually they are, unilateral. Here's a good example of a patient with sickle cell disease, had pyelonephritis, was not doing well, non-contrast. Look at the right kidney. You see what looks like a hypodense area in the right kidney? And when you give IV contrast, there's the mass. There's perfusion changes in the cortex, cystic lesion. This is classic for a renal abscess, very nicely shown in this example. Here it is on the coronal views. Again, you could consider a mass, and we can get cystic renal cell carcinomas, but the thickening of the rim and the water denser centrally and the patient's history of pyelonephritis will push you to pyelo in this case, and I don't think it's that difficult to diagnosis. Here's another patient. History was vague. They came in with flank pain. This could definitely be a cystic renal cell carcinoma, but the epicenter is more in the peri to pararenal space, and there's involvement of the psoas muscle. Yes, you can see involvement of the psoas muscle and perirenal space with tumors as well. And you could consider a cystic renal cell. This looks very similar to the last case, but this was an abscess as well. So I think it can be very challenging. This article does make the point, solitary or multifocal lesions during the early phase of pyelo or focal pyelonephritis can masquerade as tumors. So you want to be very careful. Again, when the patient has infection, treat the patient correctly. Sometimes you may have to drain abscesses. Temporal changes in lesion size and morphology after antibiotic therapy provide confirmatory proof of the diagnosis in most cases, but it can be somewhat tricky. Now, as we look at infection, there are things that are unusual. One is xanthogranulomatous pyelonephritis. So let's do this. Let's stop here and let's come back and pick it up with XGP. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.